So hi friends, back with another session here. In this video I'll be discussing about the concepts of gout, pseudogout, and I'll be discussing about the concepts of Charcots and 5 important questions. So before going in detail, we have to understand the classification of these. So under this inflammatory arthritis, we already spoke about this symmetrical, asymmetrical, we spoke about the ankylosing spondylitis, we spoke about the rheumatoid arthritis and inflammatory bowel disease arthritis, and now it's time to speak about the monoarthritis and oligoarthritis. In the monoarthritis, we'll be discussing about the gout and the pseudo, and in these oligoarthritis, which is going to involve 2 to 4 joints, we'll be discussing about this pseudo gout. So these both are known as crystal induced. So let us understand them in detail. So let me read the things written here. So under the gout, it's written according to the crystal, it is monosodium urate crystals. Epidemiology 30 to 50 years. Etiopathogenesis 90% renal defect in urate excretion, 10% exogenous like drugs induced, and you have like even the drugs like thiazides also cause. So let us understand the points written here regarding the first one, regarding the crystals. So it is monosodium urate crystals. So let us understand the points written here. So what do you mean by monosodium crystals? Say example, if this is cell and this is DNA. In the DNA is made up of purine and pyrimidines, right? Purine and pyrimidines. Now in the metabolism of the purines, you know that you're gonna get uric acid, right? You're gonna get uric acid. So now in this scenario, there is increased uric acid production, right? Increased uric acid production, and this increased uric acid production in your blood, it can be because of kidney problem, because 90% or the excretion of the uric acid is through the kidneys, and if there is a problem with the kidney, so there is no excretion of the uric acid through this urine, so there will be an increased uric acid in your blood. This can be first scenario. And second can be, you have what if there is, if you're gonna take any drugs like exogenous drugs, like if you take the chemotherapies where they're gonna break the cells and you get the DNA out, the purines that can convert into uric acid. You're gonna use some thiazides or parazinamide thiazides, they also increase the uric acids. But the point written here is regarding the crystal, it is monosodium urate crystal. So how did you get the monosodium urate crystals? So we know that this uric acid, right, which is found from these purines, what happens here is the uric acid loses one of this proton and it becomes urate ion, right? Urate ion, because it has lost H plus. So the uric acid now converts into urate ion, and this urate ion binds with sodium, and now you get the monosodium urate crystals. So this is what it's written in our notes. This is how you get the monosodium crystals. That is, the moment the cell breaks down, you get the DNA breaks down, you have purine breaks down, and it forms uric acid. Uric acid loses one of the proton and it forms urate ion, and it binds with sodium, it forms monosodium urate crystals. So the monosodium urate crystals are present in this gout. And if you look at the next one, the next will be the epidemiology. So it is found in 30 to 50 years. Fine, it's found in 30 to 50 years. That is, guys, here I told you the etiopathogenesis, that is 90% renal defect because urate excretes through the renal, or 10% it can be because of exogenous drugs that can increase the purine metabolisms, right? And even these thiazides, they also increase the uremic or urate or the uric acid in your blood. That's all we have to understand regarding the etiopathogenesis. So let us understand the clinical features written here. The clinical feature written here is, you have acute monoarthritis that gonna affect the first metatarsal, right, metatarsopharyngeal joint. second will be the ankle. And it's also written the diagnosis serum uric acid levels non-specific, and it's also written that normal acute attack. So let us understand the points written here regarding these clinical features. So right now you know the pathogenesis where there is increase in monosodium uric acid, and this monosodium uric acid can accumulate at these metatarsophalanges. So you can see this is metatarsal and this is phalanx, and this becomes metatarsophalangeal joints, and this is known as uric acid crystals. What is this? This is uric acid crystals, right? So you can see the accumulation of these uric acid crystal at the joint metatarsophalangeal joints. This is the first metatarsophalangeal joint, which is the commonest site, right? And second, there can be an accumulation. Second chance, most common is the first metatarsophalangeal, but second it can also accumulate in the ankle also. It is a monoarthritis. It's going to affect one joint here, right? And what are the diagnosis? Since there is increased uric acid levels, so for this diagnosis, the screening is we're going to look for the serum uric acid levels. It is not specific actually. It's not specific. You cannot confirm it with the gout, but it's it's just a screening test. And why it is just a screening test? Because in some conditions there might be increased uric acid in your body, and there may not be acute attacks, right? There may not be any renal failure, or there may not be any signs of acute attack of gout. So that is the reason this is non-specific for the disease here. Of course, this is useful for the screening test and can be normal even in acute attacks, right? So it can be opposite side also, right? In the normal attacks, suppose in case of acute attacks, like in renal failure, right? Like in renal failure, what's going to happen here is in the acute attacks, they may not increase the value of uric acid. It can be normal. So you cannot just consider based on the attacks. You cannot just correlate with them with the serum uric acid. So that is the reason this is not specific. So for that, what we are going to do, synovial fluid is mandatory. So let us understand what is it trying to tell us. If you look at the points written here under the synovial fluid, if you look at the synovial fluid uric acid levels, and these are more specific, and it's also written that polarizing microscopy, which is a gold standard for this gout, and this pseudo also, where you can observe needle shaped crystal with strong negative bipharynges. And it's also written that acute attack, right, like renal failure, we're going to use NSAIDs and fiboxetat, which is a xanthine oxidase inhibitor. So let us understand the concepts here. The first thing written here is, since there can be a fluctuation, that means there is no correct dependence of increased serum uric acid with the disease. Like as I have told you, in the acute attack of gout, there can be a normal values of serum uric acid. So that is the reason the more specific it will be synovial fluid. So if this is a joint which we have already observed, right, so you can just take the synovial fluid out, and we can just observe the uric acid levels, and this gives you the levels of uric acid at this joint, and this gives you the more specific as compared to the serum uric acid, right? Now when I look at this, when I take it out and when I observe these uric acid crystals under the polarizing microscope, I find something like a needle shaped crystals and with strong negative bipharynges. So what is it trying to tell us? If you look at this, for now time being, let me take the crystals from the joint and let us observe under this microscope. When we observe these uric acid crystals under this polarizing microscope, this is how it looks. You can see these are the needle shaped and with a strong negative bipharynges. What do you mean by bipharynges? If you look at these concepts, you have two scenarios. You can see one is blue and one are red, right? And the vertical placed, they are red in color, and these horizontal placed, they are blue in color. That means we have to understand that negative bipharyngescence, you have got two types of needles here. right? Two types of, one is red, right, and another is blue, and the vertical placed are, they look like red, and the horizontal placed they look like blue. So this is what the biphalanges means, and this is how the needle crystal looks. And what will be the treatment for this? For the acute attack, since there is an inflammation, we're gonna give NSAIDs. We have xanthine oxidase inhibitors. So what is xanthine oxidase? For the conversion of purine, right, for the conversion of purine to uric acid, right, we have an enzyme known as xanthine oxidase. This enzyme plays a very important role in the conversion of purine to uric acid. To block this enzyme, we're gonna block this enzyme, and to block this enzyme we have to block, because we don't want an excess uric acid in our blood or joints. So we're gonna use some drugs, and the drugs which block this xanthine oxidase are febuxostat and we have allopurinol. But in this acute attack, we are not gonna use allopurinol, we're gonna use febuxostat, because allopurinol in this acute, it has got an agonist activity that we'll be dealing. But right now, just understand that we're gonna use xanthine oxidase known as febuxostat, right? So let us understand the treatment regarding the chronic here. So chronic, we're gonna use xanthine oxidase, and now we'll be using allopurinol and febuxostat. And what is the target here? The target uric acid in your blood should be less than 6 milligram per dl. If that is more, that is an excess of uric acid in your blood. But the target should be less than 6 milligram per dl. Now say example that you have given this allopurinol febuxostat in these chronic patients, and these are, if these are ineffective, right, if these are ineffective, then we're gonna use a drugs known as peglopicase. Peglopicase is an drug. This is uricase debulking of uric. It's an uricase. It's a debulking of uric acid, and that removes the uric acid from this the collected part. This is peglopicase. It is an uricase enzyme which debulking of it does. It's a debulking of uric acid. So these are the things we have to understand regarding the peglopicase, the new drugs. Next we have other drugs also. We can use a drug anakinumab, which is monoclonal antibodies against this interleukin 1 beta. We know that this interleukin 1 that's released by these macrophages, it's fine, right? And the thing is, it is used for the reduction of pain, nothing to do with uric acid. Just to reduce the pain, we're gonna give this, right? But now let us understand what this is all about, the treatment for this acute and chronic gout. But we have to understand a few important points regarding the xanthopurinol. You know that the allopurinol and the febuxostat, it is an xanthine oxidase inhibitors. When you give this allopurinol, it's gonna be a partial agonist, right? Since it is a partial agonist, it can cause hyperuricemia, right? So that is the reason it is contraindicated in acute attacks. It can be used in the chronic gout, where it decreases the uric acid levels. But you have another drug known as febuxostat, where it do not increase the initial aspect of hyperuricemia in the acute attack. So that is the reason it is safe in acute attack also, right? And it also decreases the uric acid levels, so we can give this in the chronic gout also. So these are the important points we have to understand regarding the gout, the pathophysiologies, the all this epidemiology, the treatment, the clinical features. So now it's time to understand the basic concepts of pseudogout. Why it is known as pseudogout? So if you observe this picture, you can see this, there are swelling at this aspect. It looks like a gout, but this is a pseudogout. Why it is known as pseudogout? So let us study why it is known as pseudogout. So if you look at the points written here, you have a crystals, that is calcium pyrophosphate dihydrate, and it's also written regarding the epidemiology. It is seen in more than 50 years. If you look at the etiopathogenesis, 90% degeneration of joints, and you can see 10% it can be because of hypercalcemia, right, associated with paraneoplastic syndrome, like parathyroid hormone adenomas, right. So let us understand the points written here. Now if you look at the first crystals here, the crystals here, they are not a monosodium urate crystals. There are calcium pyrophosphate dihydrate. These are calcium pyrophosphate dihydrate crystals. Right? So this is a difference we have to understand. Now in the joints, right? If you look at the joints, the accumulation, there is no accumulation of these monosodium urate crystals. Now the calcium starts accumulating. The calcium pyrophosphates, they accumulate here. Right? So why there is increase in calcium? It can be because of degeneration of joints, and it can be because of hypercalcemia, because of increased calcium in your serum, either by degeneration of joints or because of parathyroid hormone abnormalities. So increased calcium can accumulate at the joints, right? The increased calcium can accumulate at the joints, and that can lead to pseudogout. So this is how the pseudogout looks, right? It can accumulate at that point also. So now let us understand the clinical features of this. It's an acute oligoarthritis where it can involve, the first involved is knee, next involved it can be hip, it can be shoulder, right? So these are the points we have to understand. It is an acute oligoarthritis. It's going to involve 2 to 4 joints. It can involve, first, the most common joint involved in the pseudoarthritis will be the knee. So it's going below upwards, knee, then will be the hip, then will be the shoulder. If you look at this diagnosis, since there is accumulation of calcium phosphates, that means there is increase in calcium. We're going to look for the calcium, serum calcium levels, and it's not as specific. And if you look at the next points, what will be the specific? The specific will be the synovial fluid calcium levels. And these synovial fluid calcium levels is a specific here, more specific as compared to the serum calcium. And what are these? What are these? Polarizing microscopy. If you look at the polarizing microscopies, right? So how it looks? It is somewhat like a rhomboid shape, mild positive refringes, right? So what do you mean by rhomboid shape? So they're gonna look somewhat like this, right? And if you look at this here, this is the deposit, this is the gout, this is the calcium deposited parts. So weakly positive bifringes, rhomboid shaped crystals, blue when parallel to the polarized. So it all depends, the blue and the other one which we read, it all depends upon this polarizing light, right? And this is a weakly or the mild positive bifringes, and the crystals you're gonna observe here, they look like a rhomboid shape. Of course, I don't know where actually they are. It might be somewhere here, but this is how it looks. That's it. And what will be the treatment? The treatment for the acute attack, since there is an inflammation, NSAIDs, and intra-articular steroids because there is inflammation. And if you look at these, for the chronic conditions, we're gonna avoid supplementation of calcium and vitamin D3, and we have to avoid that because already we have excess of calcium in our blood. So we have to avoid those supplementations of calcium and vitamin D3, right? Especially in elderly males. So then otherwise, if that do not cures, go for the joint replacement surgeries. So that's all you have to understand regarding this pseudogout. So now it's time to understand the Charcots disease or the neuropathic joint. And the points written here is associated disorder, most common diabetes mellitus first, leprosy second, amyloidosis, and you have motor neuron disease, syringomelia, neurosyphilis. So you have common joint effect. Most common will be the foot joint. You have ankle joints. So let us understand the points written here. You have something known as Charcots joint. So what is Charcots joint? Charcots joint is a complete collapse of the bones in the foot or ankle, right? That occurs from neuropathies. That means in this joint, the Charcots joint or this neuropathic joint, if you observe this is a Charcot foot. And normally the Charcot foot, it's nothing but this is a complete collapse of a bone in the foot or an ankle that occurs because of a problem related to the nerves, right? Because of neuropathies. And this neuropathy, the most common cause can be because of diabetes mellitus. There can be a neuropathic problem because of leprosy, that also cause a problem to the nerves. Amyloidosis, it can be because of motor neuron disease. Syringomelia, where there is a cavity in the spinal cord and which can compress the nerves. Or it can be because of syphilis, that is neurosyphilis, the tabes dorsalis, loss of coordination of movements. So these are the points we have to understand regarding the most common is diabetes mellitus first, then will be the leprosies, then follows the amyloidosis, all this. They're going to affect the nerves. Since the most common joint affected here is, that will be the foot joint, right? Foot joint will be most commonly will be affected, the foot joint. Then will be the ankle. You have an ankle joint, then these are the foot joints. So these are the points we have to understand regarding the Charcos joint, the most common joint involved. So under this we have two theories, the pathophysiologies, why there is collapse of joints. It can be, we have two theories here, that is neurovascular theory, neurotraumatic theory, neurotrauma theory. What is neurovascular theory? Under this it's written like autonomic neuropathies disrupts microcirculation of joints and there is degeneration. So what is it trying to tell us? There is a problem with this vascular aspect and the nerves. So because of these autonomic neuropathies and it disturbs, because of these neuropathies, it disturbs the circulation to the joints. If there is no circulation, the microcirculations, and that can lead to degeneration at last. Or it can be because of neurotraumatic theory, where it because of nerve trauma to the nerve, like sensory neuropathies. Like in the case of diabetes mellitus, what happens? There is no sensory sensations. The person can get a repeated trauma, micro trauma, right, whenever he walks, and that can also lead to the degeneration of joints. So these are the two theories which we have to understand regarding this Charcot's joint. So let us understand the clinical features. The points written here is, it's a painless joint, disproportionate destruction of joint. See why it is painless? Because the nerve is affected here, no pain, and there is a disorientation of the joints. They can also see the destruction of joint also, right? But when you look at the x-rays of these Charcos joint, right, whenever you look at the x-rays, now let us see the x-ray of Charcos joints. In these you can see there is something known as loose bodies in cavity, and you can see this is what the x-ray of Charcots. You can observe this half, this is the affected part, and this is how it looks in the x-ray, right? The loose bodies in the cavities, and that confirms the diagnosis. So what will be the treatment? The treatment is immobilization of joint in plaster cast, right? So to facilitate the joint, I don't know exactly, but remember that we're going to put the cast here. Then what will be the prognosis? Suppose if four joints are affected, suppose we have dependent here. So if there is 4 foot, if this is the part which is going to affect, and it takes about 3 to 4 months. Worst will be the ankle joint, which takes more than 14 months to cure. So this is what you have to understand regarding the Charcot joint, the gout and the pseudogout. Yeah. Now let's start with 5 important questions of CVS. The first question is, you can see this, the following pulse tracing best correlates with whether this is cardiac tamponade, right, digoxin toxicity, or dilated cardiomyopathies, or HOCM. So to answer these questions, we have to understand few important points here. You can see this is how the pulse looks, right? This is how it looks. You can see this in this question 41. This is a diagram which shows this is a regular pulse, but you can see this, there is alteration of the pulse amplitude. You can see this is high amplitude, there is a low, high, low, high, low, and this pulse is known as pulsus alternans, right? And the cause is left ventricular dysfunction, and this is seen in dilated cardiomyopathies. So this is what we have to understand. The pulsus alternans is the most specific pulse of left ventricular systolic dysfunction, that is a dilated cardiomyopathies. So let's go with the second question. The second will be 42, right? So this is 42. Consider the above diagram or the above tracing as normal JVP response. All the following conditions may cause the low tracing response in JVP. If you look at this, whenever the person inhales, you can see there is a drop in JVP, and exhales there is increase and drop. This is normal. But if you look at this aspect, there is opposite. Whenever there is inspiration, there is increase in JVP, and this is known as a Kussmaul sign. The JVP increase in inspiration, this is Kussmaul sign, right? And in this given question, the options are constrictive pericarditis, severe tricuspid stenosis, cardiac tamponade, and RVMI. In the given question, it's written that all of the following conditions may cause the low tracing response in JVP except. So let us see the conditions in which you can find a Kussmaul sign. Kussmaul sign is seen in constrictive pericarditis, right, restrictive cardiomyopathies. It can be seen in this severe tricuspid stenosis, and it is seen in right ventricular failure, that is pulmonary embolism, right? So this is what we have to understand. In the given option, it is seen in constrictive pericarditis, it is seen in severe tricuspid stenosis, right? It is seen in RVMV, this right ventricular failure, but this is not seen in tamponade. So it is not seen in tamponade, it is not due to tamponade. So this is what we have to understand. The given question here is, the answer is cardiac tamponade. So let's go with the 43 question. These findings are seen in, you can see this, you have ECG pattern, and you can see the P wave. You have a P wave, right, and you have all this. The P wave normally it correlates with this A, that is atrial depolarization. He is asking us whether it is atrial fibrillations or constrictive pericarditis, or you can see this, or tamponade, or all. So let us understand this 43 question. So answer is tamponade. So let us understand them. Look at P, atrial depolarization, and A tells you the atrial depolarization which correlates with the P in this ECG. And you have Y descent in this diagram, it's deep prominent here, right, deep prominent, and rapid, right, you can see this, the rapid. So what can be the cause? The cause of rapid Y descent can be tricuspid regurgitation, it can be because of atrial fibrillation, it can be because of constrictive pericarditis. So if you look at these options, atrial fibrillation, fine in the given question 43. Atrial fibrillation, constrictive pericarditis, and tamponade. You can find the Y descent in all three, but if we observe here, we cannot find a P wave in the atrial fibrillations. So you can see this. This Y descent is never seen in tamponade. In tamponade, Y is absent. So that is the reason we have ruled out tamponade here. We have ruled out tamponade because you cannot see Y descent. Now we have two options. One is atrial fibrillation and constrictive pericarditis. In the atrial fibrillations, since you cannot find P wave, so answer will be constrictive pericarditis. In this constrictive pericarditis, you can observe there is P waves, right? So this is what it's written. So let me read the things written here. In JVP shows wide descent suggestive of constrictive pericarditis. Other cause of steep wide descent are restrictive cardiomyopathies, atrial fibrillation, and tricuspid regurgitation. So let's go with the next one. The next one will be 43, right? So if you look at this, yes, where is 43, 44 now, right? So identify the condition in which the low pitch sound is heard, right? If you can see this is what the systolic part, and this is diastolic, and you can observe there is a sound at this aspect. So identify the condition in which the low pitch sound is heard. So to answer this question, we have to understand a few basics. So what are the few basics? We have a site here, S2 can be because of aortic semilunar valve closure or the pulmonary semilunar valve closure. So aortic A2 is heard best in this second intercostal space, and P2 is heard in left second intercostal space. If only S2, if they ask, then that can be best heard in second left intercostal space. But remember that both heard, right? Both are heard in the second intercostal space, but A2 is heard louder than P2, but both are heard here because this is a site of aortic area. Now if you look at this question, we have a few options, right? They can give you single S2 causes. What are single S2 causes? It can be the single S2 can be, it is because of A2 is absent, that means single P2 is heard in aortic regurgitation, severe calcification of aortic valve, and aortic stenosis. Only A2 is heard in pulmonary regurgitation, severe pulmonary stenosis, pulmonary hypoplasia. In tetralogy of Fallot, the cause of absence. So this is what you have to understand. These are the conditions it's written. In the given question, it's written that identify the condition in which low pitch sound is heard. So the answer here is low pitch sound will be atrial myomas, right? So what will be the atrial myomas? Yes. So let's go with the last question. True regarding S2, or regarding that 45. A2 is louder than P2 at pulmonary area. It's wrong. A2 is not louder. It is louder in aortic area itself. Best area to auscultate P2 is pulmonary area. Single S2 seen in TOF and all. So if you look at this, so A2 is louder than P2 in pulmonary area. So even this is also right here, right? So this is also right. A2 is louder than P2 in pulmonary area. It's right. Best area to auscultate P2 is pulmonary area. Single S2 seen in TOF. So answer is D. That is all of them are right. So this is what you have to understand. If S2 second left intercostal space, but both are heard, A2 louder than P2, right? Just understand these points. In the next session we'll be dealing about the other concepts and other 5 important questions. Thank you.